So why is oral such a big deal? Because oral is the easiest. You don't have to set up an IV line. You don't need to admit the patient for half a day to the hospital. You don't have to monitor anything. Oral is the easiest. Oral is also most convenient because you don't have to get any baseline investigations done. If the patient can walk into your office or climb 2 flights of stairs or walk for 10 or 15 minutes unsupported, that patient is fit to receive ketamine. So oral ketamine is the easiest, especially for repeated dosing. Every time, if you're giving ketamine, say on alternate days 3 times a week for 2 weeks, and you're giving it intravenously, the patient has to be admitted each time. So it is not so convenient. It's also easiest for emergency use. The patient is suicidal. The patient has not come prepared for admission. The patient does not have money. There's nobody to stay with the patient in the hospital. You have to make financial arrangements. You have to make arrangements for somebody to come and stay, so on and so forth. The patient is going back. What happens if the patient attempts or completes suicide when the patient goes back home? You see, so oral ketamine can almost be offered across the table. It is suitable for emergency use. Remember, I told you ketamine is given as an emergency treatment intravenously in a hospital, in the emergency room. The same way, oral ketamine can be given as an emergency treatment in the OPD. So oral ketamine is the easiest for emergency use. It is particularly easy for domiciliary treatment. For example, if a patient requires maintenance ketamine at a once weekly interval for a period of several months or longer, it's difficult for the patient to keep coming to the hospital each time. And how many patients can you treat with psychotherapy per week? Likewise, how many patients can you treat with oral ketamine per week if they're coming to your OPD every time for maintenance treatments? So, you might consider domiciliary treatment, and this is actually done. I told you about the Canadian study where they gave up to 300 mg of oral ketamine. Patients were told to take it at night before going to sleep and so on. Oral ketamine given as a domiciliary treatment has been done for decades in patients who are receiving ketamine for cancer-related pain, and as I told you, for depression as well. Daily oral ketamine for home use has been described in patients with chronic pain also. There are many studies over here which you can cite by way of reference in case you are asked to cite these references. Oral ketamine has been formulated as capsules, lozenges, liquid for injection can be drunk. As I told you, the taste is a little unpleasant. You have to dissolve it in about 100 ml of water. You have to compensate the dose for poor absorption because bioavailability is just 20 to 30%, but that doesn't matter. Bioavailability of lurasidone is 9 to 19%. Bioavailability of propranolol is 30% or thereabouts. Bioavailability of melatonin, ramelteon, agomeretin is about 2 or 3%. When bioavailability is low, we compensate by giving a higher dose of the drug. It is as simple as that. So if bioavailability of oral ketamine is 20 to 30%, we just give a higher dose of oral ketamine. And just the way Janssen gives, say, 56 mg or 84 mg, I give a fixed dose of between 150 mg to 200 mg. 150 mg in the first session, 175 mg or thereabouts in subsequent sessions. It doesn't have to be exactly 175 mg. A little bit this side, a little bit that side, it doesn't matter. And in some patients, I give up to 200 mg. Rarely have I needed to go more than 200 mg. I've had very few patients in whom I've given 300 mg of oral ketamine. The vast majority of patients, regardless of body weight, require around 175 milligrams of ketamine. So the bioavailability is just 20 or 30%, but that's only a number. if we are giving a fixed dose of 150 to 200 mg of oral ketamine and it's working for the patient, we just stay with that dose and it doesn't matter what the bioavailability is. We titrate the dose of ketamine to efficacy and adverse effects. It's possible that the adverse effects may define the threshold for effective dosing, but keep in mind the experience of adverse effects is not necessary for benefit of ketamine, if only because with repeated dosing of ketamine, the adverse effects tend to become less and tend to even go away. But the benefits remain. So it means the adverse effects are not important. It is not necessary for a patient to experience dissociative adverse effects, neurological adverse effects, psychomimetic adverse effects for the ketamine to be effective. So in these regards, ketamine is not very much different from other orally administered psychotropic agents. As I told you, common doses are 150 mg in the first session, and afterwards for most patients I give 175 mg. Rarely I give 200 mg, and even more rarely I give doses higher. So 150 mg is 3 ml when the concentration is 50 mg per ml. 175 mg is 3.5 ml. I administer in about 100 ml of water, actually half a glass of water, not 1/3 glass of water. 1/3 glass of water is too little for sipping. It's half a glass of water. I give it in a fixed dose as with other treatments in psychiatry, or as Janssen is giving us ketamine as a fixed dose of 56 or 84 mg. Ketamine tastes unpleasant, as I told you. Administration with fruit juice will mask the taste, but the unpleasant taste may improve the placebo effect. After all, we want the patient to get better. Patients rarely complain about the taste. Best to administer in sips spaced across 15 minutes or maybe 15 to 20 minutes in the first session. Second session maybe 12 to 15 minutes. Third session 10 to 12 minutes. And each session you narrow the duration across which the patient is sipping, but base it on the experience of the previous session. You don't want to ask a patient to sip it so fast that the patient experiences adverse effects that become unpleasant. So slower administration in the first session, faster administration in later sessions. In patients who have been taking ketamine as maintenance treatment for a long period, such patients may become so tolerant to the adverse effects that they can just gulp the ketamine down at one go. Be aware that if a patient takes ketamine too fast, nausea, neurological adverse effects, and even psychomimetic adverse effects may occur. Disinhibition, catastrophic reaction may occur if the patient thinks negative thoughts during a ketamine session. So discuss happy memories, play happy music, chat. It also makes a difference who the patient comes with. If the patient comes with a family member with whom the patient does not see eye to eye, they may not be able to talk about happy memories. That ketamine session is more likely to be associated with unpleasant symptoms and the potential to have more anxiety generated during the ketamine session. You need to do a little bit of background checking on these kind of matters before giving ketamine. Initially, do we give ketamine on an empty stomach or do you give ketamine with food? So if it's anesthesia, you want the patient to come fasting. But we are not giving ketamine as anesthesia. So when giving ketamine orally, it actually doesn't matter whether you're giving it on an empty stomach, whether you're giving it with food, it actually doesn't matter. I sometimes tell the patient, eat a little, if it's a planned ketamine session, eat a little bit and don't come on an empty stomach. Because if the patient comes on an empty stomach, maybe there's a little gastric irritation and the patient may feel, is more likely to feel nauseous. But also, if the patient comes on an empty stomach, the absorption of ketamine is faster and the dissociative symptoms, neurological symptoms, etc. tend to be more. So if the patient has a little bit of food in the stomach, the absorption of ketamine is slowed down and so the adverse effects of ketamine are less. Psychosis as an adverse effect of ketamine is so rare. I think just two patients over a period of 13 years, and that was because both patients gulped down the ketamine rather than sipped the ketamine. Risk factors of psychosis or severe adverse effects with ketamine: higher dose and faster rate of administration of ketamine on an empty stomach. Hallucinations tend to be multimodal, complex. Visual hallucinations, synesthetic hallucinations may occur. If at all you have this experience, if you take the precautions, patients are not going to experience psychosis as an adverse effect. But if at all it happens, sit with the patient, just offer continuous reassurance. The symptoms tend to last for maybe half an hour or 45 minutes. If you want, you can keep a parental antipsychotic with you in your clinic to be administered for emergency use. Remember I told you about the Canadian study? Just a little more about that study. There were 22 patients with treatment refractory depression. They were given 50 milligrams of oral ketamine to take at home in the night. The first dose was in the clinic, but subsequent doses were at home and to be taken in the night. 50 milligrams of oral ketamine at home in the night. The dose was up titrated to efficacy or to adverse effects or to futility across 1 month. Right? Futility means the treatment doesn't work. The maximum dose permitted was 300 mg. The mean dose administered was 222 mg. The frequency of administration was once in 3 days. Now, in this sample of patients with treatment refractory depression, partial response was observed in 14%, full response was observed in 18% of patients. The duration of treatment in partial full responders was for 15 weeks to up to 2 years of treatment. Domiciliary treatment with up to 300 mg of ketamine for up to 2 years, administered at home at night. So this was the study that was conducted in Canada. The response rate was very disappointing in this study, so it must have been a very, very refractory sample. As I told you, I've had experience of 2 patients with brief visual hallucinations. This was the Shiravi study, the Canadian study. In that study, 1 patient had brief visual hallucinations. Acute adverse effects were infrequent, as in other reports. There were no chronic adverse events, no cystitis, no dose escalation, no craving, no indication of misuse, despite up to 2 years of domiciliary treatment with ketamine. I'm emphasizing no dose escalation, no craving, no misuse, no chronic adverse effects developing in this sample with up to 2 years of administration.